school. Problem was he actually worked for a FACT team, for an ACT team. So he really, he thought he would do it, but then they already had an entire system in place where they were faxing the prescriptions, they worked with the particular pharmacy. So it made no sense. It was as if he was doing it just to e-prescribe. And the nurses were getting upset at him, so that kind of, fell off. But the others kind of hung on. And then we had a training session. We had the EmpowerX trainer who came and sat with the physicians who were picked to do the project. And he's been wonderful. We also had a refresher session. So he came back to make sure there were no problems or there were no questions, and periodically kind of give everyone a pep talk, make sure that the other physicians are motivated, try to kind of have the ones who really love it to talk such wonderful things about doing this so that the others get motivated. We've been able to kind of have a couple more physicians show interest and start doing the process. So we started with, actually we started with 5, and then the ACT doctor kind of didn't prescribe or wasn't able to. 1 moved away. So we ended up with mainly 2 physicians. And now this is the first 6 months. So we're talking January through June of this year. And now we have a couple more. So we have about 4 physicians right now. And in the first 6 months, we wrote 786 prescriptions. And again, I'm using the same formula that we have been provided about what the estimated cost saving would be based on $48 per patient per month for each e-script. So based on that, it's about a $37,000 saving. Now, this information is not just on the ones that we e-prescribe. It's the use of the actual device. So the drug interactions that were found, 1,530. Because, like I said, we have a couple of programs of physicians that are using the device but not e-prescribing because they have, like the ACT team physicians, they have this whole process in place where it's faxed over and the pharmacy delivers the medications and all of that. But they use it for the other purposes, not for e-prescribing, but the other stuff. So that's why you have so many drug interactions. It's like, you only have 600 plus prescriptions and 1,500 drug interactions. That doesn't make sense. Severity 1, 47, severity 2, 458, severity 3, 884, and severity 4 was 141. And that's the data provided to us by EmpowerX. So if you added the 1 and 2 category of severity intensity, there were 505. And 5% of severe and major risk drug interactions, if that resulted in hospitalization. Now that is just based on what information we're provided. It probably would be good, maybe what I will do next time is ask the physicians to keep track and see not just whether their patients ended up in the hospital, but also to see if they changed their practice. Because if it pops up, a lot of times people just go back to the manifest and do what you're doing and prescribe, because most of the patients are usually stable on medications. So that might be good to find out, to see if they can keep track of that, and maybe we can have like a data collection to see if really there is change of practice and whether there is any negative outcomes. Again, in the first 6 months, the estimated potential cost savings is $154,000. Now, I'm not saying that is the cost saving. That's based on that formula. Again, this is data based on our 5 or 6 physicians that do use the handheld to get information about their patients, to see if there are other physicians prescribing the same category of medication. Sometimes patients don't know. You might be going to a primary care physician and that physician is prescribing Zoloft or sertraline, and then they come to us and we are prescribing something else, maybe citalopram, something like that. not knowing that the patient is on the same type of medication for the same problem. So it's not necessarily doctor shopping, although we have that also with other medications like the benzos and the controlled substances. Clinical reports were ran 701 times to find out if there's any other medications the patient is on. We want to know what other medical medications they're on. The monograph was viewed. We have that information right on our hands, which is very helpful to, if a patient is on a medication, you don't know what it is, you can check that out. Might be something for blood pressure or something like that, which we may not have knowledge on, so that really helps. And the Florida Best Practice Guidelines were viewed 14 times, which is better than nothing. Okay, so what are the barriers that we identified? Of course, the biggest one is the apprehension related to technology use and malfunction, complaining about, oh, we have to synchronize and this and that, and if it freezes, then you have to call the help desk, and it's generally about half hour on the phone, which we don't have, and then the problem is to log on each time. It just logs off, and then you log on. It's like 7 or 8 little clicks before to put in your password, and then suddenly it pops up. Password has to be changed, and so all of that gets a little too crazy for clinicians are like, oh my God, can't do it. So the apprehension-related technology use, that's a big issue, especially when you have physicians that have been there and doing what they've been doing for so many years. Then the availability of technology and tools. Now that's also an issue because some of our physicians, since we are so spread out with so many offices, we also have some programs where they're there 2 days a week. So they just go, and they don't have a designated office, and you can't really have a computer at every location. So that's a cost issue, and the availability of technology and tools and all of that. That becomes an issue, especially if they are not in a designated office. Some negative experiences, patients being told by the pharmacy that they did not receive the e-script. Now, that has happened. That happens periodically, and so the problem is that the patient gets irate. If you write a prescription and you give it to the patient and they lose that prescription, then they're calling you to say, oh, I'm sorry, I lost the prescription, can you please call it in? And then when you do an e-script and they go to the pharmacy and it's not there, you get the heat, you say. So that's a problem. Calling you saying, yeah, you said you e-prescribe and there is no e-prescription and blah, blah, blah. So that is a problem. So we're always like, okay, don't worry, we'll call it in. And then that's additional time. And then that's inconvenience because sometimes, like I said, the physician is not in an office. They're coming back 2 days later and the nurse is calling and, it just gets a little hectic. So. And the problem that I have encountered is that if I am looking at my handheld and I see that the prescription was filled 2 weeks ago, that means the patient still has another 2 weeks supply of medication. So if I e-prescribe, I am really not confident. So I've actually stopped doing that because I have had pharmacies delete prescriptions or tell them, it's like it's gone. If it's within a week, I e-prescribe. So if it has been like just 2 weeks ago they filled it because for whatever reason they had a little bit of extra medication, they have another 2 week supply, I am a little nervous that it's going to get deleted. And it has happened. The pharmacy said, oh, I don't know, it must have gotten deleted. It's not there, sorry. So then again, you have to call in prescriptions and the patients are not comfortable because they don't have a prescription in their hand, especially the compulsive patients. And then, again, like I mentioned earlier, too many steps, startup time, click, 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 it goes away, then you do all of that, and you're sitting here and you have 5 prescriptions to keep, e-prescribing, so sometimes it's easier while you're talking to write the prescription. It's much faster, you're done, you give it to them, rather than, each time you're clicking and it goes to the next 1, 2, 3, 4, 5, so there are multiple prescriptions. It actually may take longer than writing a prescription. Now, adding patients to the manifest, that takes a lot of time. And sometimes you don't know if a patient is